Hello, and welcome to a session of Digital Slide Review and Sign Out. I'm Dr. Lewis Hassel, coming to you from the campus of the University of Oklahoma Health Sciences Center in Oklahoma City. Our case today comes from the realm of GI pathology. The patient, who was seen at first at an outside hospital, is a 55-year-old woman with intermittent right upper quadrant pain for many years. Of course, with that kind of history, the gallbladder was immediately suspect, and a willing surgeon was found to remove the gallbladder. However, unlike most gallbladder surgeries, this case had some complicating twists, and the very astute outside pathologist noted an area of mural thickening in the wall, and this he sampled very appropriately, and here we see a representation of this section. Let's just turn it around here so we can look at it right side, top to bottom here. As you can see, we have the muscular wall here, which is slightly thickened by some sort of a mixed epithelial proliferation here. And then we have a fatty serosa here. So let's go here first over here and look and see what's on the surface and what's going on here. So here, the surface mucosa looks fairly unremarkable. We have some typical Rogowski-Aschoff sinuses that here extend through the wall, but are not involved by any sort of dysplasia or atypicality. Here, there's a little bit more proliferation to these glands, but again, they look fairly benign, fairly low grade, and very similar to those overlying them. As we come along here, though, we begin to see a change, and this sets us up both in terms of architecture and the pattern here to distinguish between this type of a process and this smaller glandular process. So moving further along here into the lesion, we note that there are areas where we have some larger spaces, some of which have mucinous content associated with some of these infiltrative type processes, and other glands like this which still appear fairly normal. Even here, very close to the surface and center of the tumor, we can see some areas where the glandular epithelium looks fairly benign and typical. But then adjacent, we have this complex pattern of large and small glands with an desmoplastic type stroma or a mucinous type stroma around it, an inflammatory reaction going along with it, almost as though there's been a polyp here, and then deep to this polyp is this invasive neoplasm that has glandular configuration that is fairly small. Now, very often, gallbladder carcinoma will invade the adventitia and line up to find the nerves and other paths of least resistance. So it's certainly appropriate to look for perineural invasion in areas like this around vessels. We're not seeing that right off here. Also, we'll just call attention to this sort of an area here. And notice the difference in staining character between these glands and the ones surrounding them. It's very possible that these are entrapped Rogowski-Aschoff sinuses that have been surrounded and impressed upon by the tumor, although there may be some tumor associated with them. But very often this picture can become quite confusing, and distinguishing between otherwise benign Rogowski sinuses or adenomyosis can become very challenging for us in gallbladder carcinomas. So let's just assume here we've got the evidence of a gallbladder carcinoma. We have areas where it looks like we have better differentiated tumor or potentially just adenomyosis, as well as clear-cut areas of more poorly differentiated gland-forming tumor with abundant mucinous and myxoid inflammatory stroma. So WHO classifications of gallbladder carcinomas, of course, the largest category is adenocarcinoma, but that has many nuances and many flavors. There are intestinal type carcinomas, which look much like those you'd see in the lower GI tract, as well as biliary type carcinoma. Some gastric foveolar type cells can also become neoplastic. And then we have pure mucinous or mixed mucinous and signet ring or poorly cohesive carcinomas, much as we see in other areas of the upper GI tract. Rarely clear cell carcinomas have been reported in this location. And then some lesions which we usually think of as being primarily pancreatic, such as IPMN or mucinous cystic neoplasm, can also present in the gallbladder with or without an associated invasive carcinoma. Goblet cell carcinoma, a variant of neuroendocrine carcinomas, well-differentiated variant is possible here, as well as adenosquamous, and then more conventional large and small cell neuroendocrine carcinomas, as well as then the mixed types of neuroendocrine and non-neuroendocrine carcinomas. Finally, a small percentage represent totally undifferentiated carcinomas, which cannot be further classified. So one of the main precursors of adenocarcinoma is glandular dysplasia. And so I want to show you this case in this slide, which nicely illustrates some of the difficulties in detection. Because first of all, we don't usually see much in the way of abnormalities to the mucosa when examined grossly. As you can see, there's really not much here to distinguish it in terms of maybe a little bit of hyperemia. There's certainly no mural thickening. And so detecting mucosal dysplasia can be challenging. That's certainly on the gross side of things. Microscopically, it's less of a problem if our index of suspicion is appropriate. First of all, we can see that the glands become hyperchromatic. And so hyperchromasia, particularly in the setting where you may have associated submucosal or intramucosal glands without that degree of hyperchromasia, is a very useful marker. And you can see that we get many of the typical features of glandular dysplasia with nuclear crowding, stratification, some karyarexis, maybe a karyorectic debris, loss of polarity to some degree, and perhaps increased mitotic activity, such as you see here in these glands. Now, this is intestinal type metaplasia, of course, and dysplasia, and would be most commonly a precursor of intestinal type adenocarcinomas. With that particular type of adenocarcinoma and with this type of dysplasia, we become aware of one of the pitfalls associated with the diagnosis of gallbladder carcinoma. And these are several key pitfalls that were detailed by my colleagues, Dr. Zhang and Dr. Ngop, several years back while visiting in our department. So clearly the most frequent reason for non-detection or for non-diagnosis or improper diagnosis is that we under or incorrectly sample areas of the gallbladder, or we miss very small occult areas such as such well-differentiated tumors that may masquerade either as serosal inclusions or small areas of carcinoma involving the submuscular tissues that masquerade as Aschoff-Rokitansky sinuses. But when CIS or dysplasia begins to involve adenomyosis and these crypts of Rokitansky, then it becomes extraordinarily difficult to correctly identify it as potentially invasive or non-invasive. Additionally, some additional pitfalls from their review were mistaking a primary neuroendocrine tumor for metastatic carcinomas. And these, of course, these carcinomas in the gallbladder are less frequently encountered than in other sites, but we need to remember that primary tumors can occur there. Also, mucinous neoplasia in the setting of pseudomyxoma obviously most commonly comes from the appendix, which we've talked about in other videos, but can arise from mucinous neoplasia in the gallbladder as well. And then two last ones less frequently, tumoral necrosis can be mistaken for gangrenous necrosis, and overlooking or ignoring small extracellular mucin pools in the setting of low tumor mass can be a diagnostic pitfall. So I'll just illustrate with one further slide here how challenging sometimes these diagnoses can be. And so here we see a thickened gallbladder wall, and we see areas of slight desmoplasia here, and some dilated glandular structures. So first, in looking at evaluating this, let's look at the surface mucosa and consider what kind of epithelium we have here. We can see that it's columnar. The nuclei are mostly basally located, and there's a moderate amount of probably mucin-containing cytoplasm, a little bit amphiphilic here. We have some vascular ectasia here. And then let's compare that to what we're seeing down deeper here in the wall, where we're seeing this desmoplasia and inflammation. Now, granted, these glands are somewhat misshapen. They're triangulated or branching sort of things. But if we compare this epithelium, it is virtually identical to what we were seeing on the surface. So if we have surface dysplasia and we have this type of tissue in the Aschoff-Rokitansky sinuses, and we begin to see this type of stromal desmoplasia, it's very easy to jump to a diagnosis of invasive neoplasia. And that is a potential pitfall, potentially resulting in overtreatment of the patient when only evaluation of dysplasia may be required. So we need to be very careful about this particular pitfall, which is probably the most frequently encountered one in working with this oft resected organ. So remember those pitfalls, and remember the varieties of gallbladder carcinomas that can occur. We'll present and share some other types perhaps in a subsequent video. So our final diagnosis today is adenocarcinoma of the gallbladder, biliary type, arising potentially from a gallbladder polyp in this woman with a history of stone disease and intermittent abdominal pain. Well, thank you for joining us. We appreciate the opportunity to share these videos with you and hope that they'll be useful to you in your practice. Please comment below on any other pitfalls you may have encountered in diagnosis of gallbladder carcinoma and what you've learned to do to avoid that. Please share this video with others who may be interested in similarly learning. And of course, please subscribe so that you don't miss future offerings on our channel. So until next time, thanks so much for joining us.